class, we will discuss about the uterus. Uterus is a child-bearing organ in females. It is situated in the pelvis between bladder and the rectum. Although it is hollow, it is thick-walled and firm. It can be palpated bimanually during per-vaginal examination. The uterus protects and provides nutrition to the fertile womb, enabling it to grow into fully formed fetus. At the time of the parturition, contraction of the uterine muscles results in the contraction of its walls and it expels the fetus from the uterus. Here in this dissection you can see the uterus present in the pelvis. This is the fundus of the uterus, here is the body, this is the uterine tubes, this is the ampulla, and here you can see the urinary bladder, and posteriorly you can see the rectum, and here you can see the peritoneum. From the superior surface of the bladder reflects onto the anterior surface of the uterus, forming a pouch known as vesico-uterine pouch. This is the vesico-uterine pouch. Similarly, here you can see the peritoneum reflects from the uterus onto the rectum, forming the recto-uterine pouch. The uterus is piriform in shape, about 7.5 cm long, 5 cm broad, 2.5 cm thick, and weighs about 30 to 40 grams. The uterus is divisible into an upper expanded 2/3 part of the which consisted of the body, and the lower cylindrical 1/3 part, that is the cervix. The junction of the body and the cervix is marked by a circular construction known as isthmus. The part of the body that lies above the fallopian tube is known as fundus. The superior-lateral angles of the uterus they project outwards at the junction of the body and the fundus, and it is known as carnum of the uterus. The uterine tubes, the ligament of the ovary, and the round ligament of the uterus are attached to it on each side. Normal position and angulation. The long axis of the uterus forms an angle of about 90 degrees with the long axis of the vagina. This angle opens forwards. The forward tilting of the uterus relative to the vagina is called anteversion. Contrary to this, the backward tilting of the uterus relative to the vagina is known as retroversion. The uterus is also slightly flexed at the level of internal os of the cervix, that is the anteflexion, which has an angle of about 125 degrees. The long axis of the uterus roughly corresponds to the axis of the pelvic inlet. The long axis of the vagina roughly corresponds to the axis of the pelvic cavity and the axis of pelvic outlet. Uterus is normally deviated to the right side, and this condition is known as dextrorotation. Here in this diagram you can see the long axis of the uterus and the long axis of the vagina. This forms an angle of 90 degrees, and this is known as the angle of anteversion. Here you can see The long axis of the uterus makes an angle of about 170 degree with the long axis of the cervix. And this angle is known as angle of anteflexion. Here in this dissection, you can see the carno, and you can see the angulation of the uterus here. That is the long axis of the uterus. It is making an angle with the long axis of the vagina. Now, here you can see the uterine tube. This is the fimbria and the ampulla. So swelling in the ampulla here. Here what you can see the ovary, and this is what you can see is the ligament of the ovary, and this is what is lying is the broad ligament. The posterior layer of the broad ligament by which the ovary is suspended is known as meso-ovary. Here posteriorly you can see the retro-uterine pouch, and anteriorly here you can see the reflex of the peritoneum onto the superior surface of the bladder, that is the vesico-uterine pouch. Communications. The uterus superiorly communicates on each side with the uterine tube. Inferiorly, it communicates with the vagina. Then, coming to the parts of the uterus. The uterus comprises of fundus, the body, and the cervix. Body has got two surfaces, that is anterior and posterior, and it has two borders, that is right and left. The fundus is a convex upper part of the uterus. It is convex like a dome. The free upper end lies above the openings of the uterine tube. It is covered by peritoneum. It is directed forwards if bladder is empty. The site of the implantation of a fertile ovum is the fundus. Then coming to the surfaces. The anterior or the vesical surface of the uterus is flat. It is related with the urinary bladder. It is covered with peritoneum, which forms the utero-vesical pouch. Here, in this median sagittal section of the pelvis, you can see the body and the cervix. Here, you can see the uterus forms an angle with the long axis of the uterus forms an angle with the long axis of the vagina. That is the angle of anteflexion. Here you can see the vesico-uterine pouch. Here what you can see is the pubic bone, and this is the retropubic fat which separates the pubic bone from the urinary bladder. The posterior surface of the uterus is convex. It is related with the coils of the terminal ileum and sigmoid colon. It is covered with the peritoneum, which forms the recto-uterine pouch. There are two lateral borders. The lateral borders, they are rounded and convex. It provides attachment to the broad ligament of the uterus, which connects to the lateral wall of the pelvis. At the upper end, the uterine tubes open and the round ligament of the uterus and the ligament of the ovary. The uterine artery ascends between the two layers of the broad ligament. Cavity of the uterus. On sagittal section, it is slit-like. In coronal section, it is triangular in shape. The apex of the cavity is directed downwards and continuous with the canal of the cervix. At the junction of the cervix lies internal os. The superior-lateral angles receive the openings of the uterine tube. The cervix. Cervix is a lower cylindrical part of the uterus. It is less mobile than body. It is about 2.5 centimeter long. It is slightly wider in the middle than at the either end. The lower end projects into the anterior wall of the vagina, and this vagina divides the cervix into two parts, the supravaginal part and the vaginal part. The supravaginal part, that is the part of the cervix which lies above the vagina. Anteriorly, it is related to the bladder. Posteriorly, it is related to the recto-uterine pouch, which contains the coils of ileum and to the rectum. On either side, it is related to the ureters, and uterine artery is embedded in the parametrium. Here in the sagittal section of the uterus and vagina, you can see the uterine cavity is slit-like. This is a slit-like uterine cavity. And here you can see this is the body and this is the cervix. And at the junction of the body and the cervix there is internal os. Anteriorly, here you can see the vesico-uterine pouch, which is formed by the reflection of the peritoneum from the superior surface of the bladder onto the anterior surface of the uterus. Here you can see the cervix opens into the vagina to the external os. So there are two os, the external os and the internal os. The internal os at the junction of the cavity of the body of the uterus and the cavity of the cervical canal. And the external os is the opening of the cervical canal into the vagina. Here you can see the anterior wall and this is the posterior wall. And you can appreciate that the uterus protrudes inside the vagina, that is to the anterior wall. Here in this dissection you can see the uterine cavity. It is triangular in shape, okay, having a base, the apex here. And this cavity, uterine cavity, you can see it communicates with the cervical canal at the lymph junction at the internal os. The internal os is the narrow constricted part between the uterine cavity and the cervical canal. The cervical canal, here you can see it opens into the vagina. Here this uterus and vagina has been viewed from the posterior aspect. The posterior wall of the uterus and the vagina has been removed to expose the cavity of the uterus, the cavity of the cervix and the vagina. Parametrium. The parametrium is a fibrofatty tissue between the two layers of the broad ligaments and below it. It is most abundant near the cervix and vagina. The vaginal part projects into the anterior wall of the vagina. The space between it and the vaginal wall are called the fornixes. The cervical canal opens into the vagina through the external os. In nulliparous, the internal in nulliparous, the external os is small and circular. In multiparous, the os is abounded by anterior and posterior lips, both of which are in contact with the posterior vaginal wall. The cervical canal is fusiform in shape. It communicates above with the uterine cavity through the internal os and below with the vaginal cavity through the external os. The cervical canal is flattened from before backwards. The mucosa shows folds resembling branches of the tree, and this arrangement of the mucosa is known as arbor vitae uteri. These mucosal folds interlock anterior and posterior walls and of the cervical canal, and they close the canal. Here, in this section, here you can see the uterus and the vagina. Here the posterior wall of the vagina has been cut and removed, and you can see the external os of a multiparous woman having a anterior lip and a posterior lip. The space between the vagina and the cervix is the fornix. Here between the cervix and the anterior wall, it is the anterior fornix. Cervix and the posterior wall is the posterior fornix, and cervix and the lateral wall is the lateral fornix. So there is one anterior fornix, one posterior, and two lateral fornixes. Here you can see the degrees of the vaginal mucosa. Then coming to the ligaments, peritoneal ligaments of the uterus. These peritoneal ligaments are mere peritoneal folds which do not provide any support to the uterus. There is anterior ligament known as utrovesical fold. There is a posterior ligament known as rectovaginal fold forming the rectovaginal pouch. There are two lateral ligaments, that is the broad ligaments, right and the left broad ligaments. These are the folds of peritoneum which connect to the lateral wall of the pelvis. Now, when the bladder is full, this broad ligament has got an anterior and a posterior surface, a upper, a lower, a medial, and a lateral borders. The upper border is free. The anterior and the posterior layers of the peritoneum are continuous here. The lateral and the inferior borders are attached to the corresponding parts of the pelvic wall, while the medial border is attached to the lateral margin of the uterus. The ovary is attached to the posterior layer through the mesoovarium. The ligament of the ovary passes from the lower pole of the ovary to the lateral angle of the uterus. The mesosalpinx is a part of the broad ligament between the uterine tube and the ligament of the ovary. Then mesometrium, that is the part of the broad ligament below the ligament of the ovary. Then suspensory ligament of the ovary are also known as infundibulopelvic ligament. It is a part of the broad ligament that stretches from the upper pole of the ovary and infundibulum to the uterine tube to the lateral wall of the pelvis. Here you can see the broad ligament. This is the peritoneal fold which is attached along the lateral border of the uterus here, and from here it extends to the lateral wall of the pelvis. So this whole is the broad ligament. It has got a upper border here, the lower border, a medial border and a lateral. Upper border is free and it lodges the uterine tube. Here it has got two layers, an anterior layer and a posterior layer, and the two layers are continuous here at the upper border. Now, here this broad ligament you can see it contains the uterine tube, the ligament of the ovary. Yeah, is a ligament of the ovary. Here you can see the this is the broad ligament. This is seen in a sagittal section of the pelvis. Here you can see from the lateral border extends the broad ligament, and here you can see the round ligament of the uterus. This is the uterine tube, the fimbria. Here you can see the ovary. This is the mesoovary. That is the, and here is the ligament of the ovary. The mesoovarium is a part which lies between the uterine tube and the ligament of the ovary. This is what you can see, the rectouterine pouch that is reflecting, peritoneum is reflected from the posterior surface of the uterus onto the anterior surface of the rectum. And this is the vesicouterine pouch, that is the peritoneum between the urinary bladder and the uterus. The structures present in the broad ligament. It consists of uterine tube, the round ligament of the uterus, the ligament of the ovary, the ovarian vessels in the infundibulopelvic ligament, the uterovaginal and the ovarian nerve plexuses, utuforan, paraphoran. There are some lymph nodes and lymph vessels. There is a dense connective tissue or the parametrium present on the side of the uterus. Then the fibromuscular ligaments. These form the true ligaments. They support the uterus. They consist of round ligament of the uterus, the transverse cervical ligament, and uterosacral ligament. Arterial supply. The uterus is supplied chiefly by two uterine arteries which are markedly enlarged during pregnancy, and partly by ovarian artery. So, two uterine arteries and partly by ovarian artery. The uterine artery is a branch of anterior division of internal ileum. It first runs medially towards the cervix, crossing the ureter above the lateral fornix, lying 2 centimeters lateral to the cervix. This is very important while doing the operation of hysterectomy. So this relation is very important to preserve the ureter. This artery ascends along the side of the uterus with the tortuous course. Finally, it runs laterally to the hilus of the ovary and ends by anastomosing with the ovarian artery. The tortuosity of the uterine artery permits expansion of the uterus during pregnancy. This uterine artery also supplies vagina, medial to third of the uterine tube, ovary, ureters, and structures present in the broadly community. Here in this section, you can see the uterine vessels. Here, this is the in, internal iliac artery, and this gives the uterine artery. Here, anterior division gives the uterine artery. Here you can also see the ovarian vessels. Here, these are the branches of abdominal aorta, and this ovarian vessel supplies the ovaries and anastomosis with the uterine artery. Here in this diagram, you can see the arterial supply. You can see the ovarian artery here, branch of abdominal aorta, and here you can see the uterine arteries. They are coming as a branch from the anterior division of the internal iliac. It reaches to the side of the cervix, then it ascends up. It has got a tortuous course and it anastomosis here with the ovarian artery in the infundibulopelvic ligament. The venous drainage. The veins of the uterus form a plexus around the lateral border of the uterus. This plexus drains through the uterine, ovarian, and vaginal veins into internal iliac vein. Here you can see the plexus of veins formed by the uterine veins, and from here the veins drain into the uterine vein, into internal iliac, into along with the ovarian vessels and with the vaginal vessels. Lymphatic drainage. The lymphatics, they begin at three intercommunicating networks, that is the endometrial, myometrial, and subperitoneal, which drain into the lymphatics on the side of the uterus. The upper lymphatics from the fundus and upper part of the body drain mainly into the aortic nodes and only partly into the superficial inguinal nodes along with the round ligament of the uterus. The lower lymphatics from the cervix drain into the external iliac, internal iliac, and sacral. The middle lymphatics from the lower part of the body drain into the external iliac lymph nodes. Here in this diagram you can see the lymphatic drainage from the upper part into, you can see the lymphatic pass to the aortic group of lymph nodes, the lateral aortic, the pre-aortic, from the Middle part of the body, you can see it goes to the external iliac nodes. From the lower part of the cervix, you can see the lymphatics, they go to the external iliac and you also go to the internal iliac. Few lymphatics, they pass with the along with the round ligament of the uterus to the superficial inner lymph nodes. Nerve supply. The uterus is richly supplied by both sympathetic and parasympathetic nerves through inferior hypogastric and ovary plexuses. The, sym- the sympathetic nerves are derived from the T12 and L1. They produce uterine contraction and vasoconstriction. The parasympathetic nerves are derived from S2 to S4 segments. They produce uterine inhibition and vasodilatation. The effects of the nerves are complicated by pronounced effects of hormones on genital tract. The pain sensations from the body pass through the sympathetic nerves, while from the cervix pass through the parasympathetic nerves. Here you can see the nerve supplies in this diagram is the sympathetic chain. You can see the sympathetic fibers are derived from T12 and L1 segment, and this is the hypogastric plexus, superior hypogastric plexus having root value S2 to S4 parasympathetic and T12 to L1 sympathetic. Therefrom here you can see the plexus gives the hypogastric nerve which form the inferior hypogastric plexus, yeah, and supplies the uterus and cervix. Then coming to the clinical correlation of the nerve supply that is required for the anesthesia for the parturition. The spinal anesthesia by a lumbar puncture into the subarachnoid space produces complete anesthesia of the uterus, cervix, vagina, perineum, lower extremities, and inferior abdominal wall. It is the most common form of anesthesia given for the cesarean section. So, this is the lumbar puncture. Then, lumbar epidural anesthesia. It, it produces similar anesthesia to the caudal epidural but with a great anesthetic effect on the uterus. The epidural lumbar anesthesia is given most commonly for the anesthesia during vaginal delivery. This is known as painless delivery. Then the caudal epidural block via injection through the sac, hiatus and canal is paths S2 to S4 spinal nerves, roots, excising the cervix, vagina, and the perineum. It does not affect sensations from the structures which lie above the pelvic rim, that is the body and the fundus. Then pudendal nerve block. Here, it is a local anesthesia of the perineum given by blocking the pudendal nerve having the root value S2 to S4. Then the age changes and age and the reproductive changes in the uterus. In the fetal life, the cervix is larger than the body, which projects a little above the pelvic rim. At puberty, the uterus enlarges and descends to the adult position. The arbor variety they also appear in the mucosa. During menstruation, the uterus slightly enlarges and becomes more vascular. The lips of the external os are also swollen. During pregnancy, the uterus enormously enlarges, mainly due to the hypertrophy of the smooth muscle fibers and partly due to hyperplasia. As pregnancy advances, the uterine wall becomes progressively thinner. After parturition, the uterus gradually involutes and returns to the almost normal, almost non-pregnant size. In the old days, the uterus becomes atrophic and is smaller in size and more dense. The internal os frequently obliterates and the lips of the external os disappear and the os is itself may be obliterated. This is the ultrasonography of the normal adult uterus. You can visualize the uterine cavity. You can see the uterus, body of the uterus, cervix. You can take the measurements. There is a longitudinal, there is a transverse. This is the transvaginal ultrasonography done for the uterus. You can very well visualize the detailed structure of the uterus. You can see the uterine cavity. This is the epithelium, that is the endometrium, lining endometrium of the uterine cavity is the myometrium. You can see, and here you can see the perimet. This is what you can see is the body of the uterus, is the fundus of the uterus, and here you can see the cervix. This is the hysterosalpingography. You can put a iodine dye in the cavity of the uterus. You can visualize the cavity of the uterus, and you can see the patency of the uterine. Here you can see the uterine tube. This is the ampulla, and here is the fimbria. You can see the spleen of the dye in the peritoneal cavity. This is the hysteroscopy. You can visualize the cavity of the uterine tube, uterus by putting a hysteroscope, and you can visualize any growth in the cavity of the uterus. Most commonly that is the polyps, and they can be treated, they can be removed. This is how this uterine cavity is visualized. It is seen in the hysteroscopy. Here you can see the image of the opening of the uterine tube. Then coming to the supports of the uterus. The supports of the uterus prevent the sagging down of the uterus. The supports are divided into primary supports and secondary supports. The primary supports consist of muscular and the active supports. The muscular supports consist of pelvic diaphragm, the perineal body, and distal urethral sphincter mechanism. The fibromuscular are the mechanical supports. They consist of uterine axis, the pubo-cervical ligaments, transverse cervical ligaments of the Macken rods, the uterosacral ligaments, and the round ligaments of the uterus. Here, in this dissection, you can see the levator and eye muscle forming the pelvic diaphragm. It is attached as a periphery to the pubic and the pubic bone and to the ilium here, posteriorly to the sacrum. Here you can see how the vagina passes to the pelvic diaphragm. This is here to visualize the parts of the levator and eye muscle. The levator and eye muscle has got three parts, that is the pubococcygeus, iliococcygeus, and anococcygeus. Here, anococcygeus. This is the tendinous arch over the orbiter internus from which the this levator and eye muscle originates. Here you can see the uterine axis, the long axis of the uterus, and the long axis of the vagina, forming an angle of antiversion. Here you can see the antiflexion, the long axis of the uterus and the long axis of the cervix forms an angle of about 170 degree. That is the angle of antiflexion. Here in this diagram, you can see the fibrous supports. You can see the urinary bladder, the cervix is the rectum, and here you can see the pubocervical ligament. Pubocervical ligament passing from the cervix to the pubis. Here you can see the transverse cervical ligament passing from the cervix to the lateral wall of the pelvis. And this is the uterosacral ligament passing from the posterior surface of the cervix onto the sacrum. Here in this diagram you can see how the pubocervical ligament and uterocervical ligaments, sacral ligaments, they support the uterus from the side. Secondary supports, they consist of the peritoneal ligaments. They are of doubtful value. These ligaments they include the broad ligament, the vesico-uterine pouch and fold-up peritoneum, and rectovaginal or the recto-uterine pouch and fold-up peritoneum. Here, in this dissection, you can see this is anterior support here, that is the vesico-uterine pouch. Here you can see the recto-uterine pouch posteriorly, and on the side here you can see the broad ligament. You can see the broad ligament of the uterus. Then the supports they can be classified into three groups. In the upper part, they have the round ligament and broad ligament. In the middle part, you see the transverse ligament, pubocervical ligament, and the uterocervical ligaments. In the lower part, you find the urogenital diaphragm, the levator, ani, and perineum. The perineal body is a fibromuscular node to which 10 muscles are attached. This perineal body is very important as support of the uterus. It acts as an anchor for the pelvic diaphragm and thus it maintains the integrity of the pelvic floor. The muscles attached to the perineal body consist of two superficial transversus perineae, two deep transversus perineae, two pubococcygeus, two bulbospongiosus, and a single sphincteri externus and unstrapped muscle of the longitudinal muscle cord of the anal canal. Then the transverse cervical ligament of McEnroe's. This is a fan-shaped condensation of the endopelvic fascia on each side of the cervix, above the levator and round and around the uterine vessels. It connects the lateral aspect of the cervix and upper vaginal wall to the lateral pelvic wall, about 2.5 centimeter ventral to the ischial spine. So this ligament lies about 2.5 centimeter ventral to the ischial spine. Now this McEnroe ligament forms a hammock that supports the uterus. Then another important ligament is the uterosacral ligament. Uterosacral ligament is a condensation of endopelvic fascia which connects the cervix to the periosteum of the sacrum and are enclosed within the recto-uterine folds of peritoneum. It keeps the cervix braced backwards against the pull of the round ligament. The two ligaments they form a couple that maintain the uterine axis. Then the round ligament of the uterus. The round ligament of the uterus is a fibromuscular band, flat band, 10 to 12 centimeters long. It lies between the two layers of the broad ligament, anteroinferior to the uterine tube. This ligament begins at the lateral angle of the uterus. It runs forwards and laterally, passes through the inguinal canal and merges with the aerial tissue of the labia majora after breaking into the filaments. In the inguinal canal, it is accompanied by a process of peritoneum during fetal life. If it persists after birth, it is also known as females as canal of Nack. Now this ligament keeps the fundus pulled forwards and maintains the angle of cantiversion against the backward pull of uterosacral ligament. Histology. The uterus consists of three layers: inner mucous membrane, also known as endometrium. This endometrium undergoes cyclic changes in three phases. That is the proliferative phase. Lining comprises of simple columnar epithelium. Stroma contains simple tubular glands. The deeper part contains coiled arteries. In progesterone phase, the glands get sacculated and tortuous. The coiled arteries are seen in the superficial part of the thick endometrium. In menstrual phase, the endometrium becomes ischemic and starts shedding. The vessel wall gets necrosed and blood enters the stroma. The menstrual flow starts. The myometrium is thickest layer made up of an outer and inner longitudinal layer and a middle circular layer with knots of arterioles. The serous lining of the peritoneum forms the outer covering. Here in this diagram, you can see the endometrium, you can see the myometrium. This endometrium shows, and this is the inner layer of the simple columnar epithelium. This is the, you can see this is the stratum functionale. This is the basal layer. Here you can see the endometrium glands, and this dense part is the stratum basic. So this superficial part here, this is the functional stratum functional which sets out during menstruation, and here you can see the dense part which retains after menstruation. Development. The uterus develops from two paramesonephric or the Mullerian ducts. These paramesonephric ducts they arise on the surface of the urogenital disc. Cranially, this duct opens into the abdominal cavity as a funnel-like structure, and caudally, the two paramesonephric ducts they join in the midline to form the uterine canal. In this diagram, you can see the paramesonephric ducts or the Mullerian ducts. They join in the midline. This intermediate wall that disappears, and the uterine septum disappears, and the lumen of the uterus is formed. This paramesonephric duct forms the cervix, the body, the cervix, and the fornix of the vagina, while the lower part of the vagina develops from the sinovaginal bulb. Here you can see the abnormalities of the uterus. Anomalies: if the partition does not disappear, there is condition known as uterus diaphylis with double vagina. So two uterus, two vagina. If partially septum persists, then there is indentation in the uterine cavity known as uterus arcuatus. If here you can see the upper part of the uterine tube, the Mullerian ducts, they remain unfused while only the lower part is fused. So the uterus is bicarnate. Then uterus bicarnate uniculus is two cornua are present but one cornua is atrophied at the rudiment. Then applied anatomy is semi-sitting posture. The secretions collect in the pouch of the Douglas. So in the cases of the pelvic inflammation, you will find fluid in the pouch of the Douglas or the recto-uterine pouch. A perforating injury can occur through the posterior fornix involving peritoneum. So foreign body may enter here. Then the supports of the uterus also support the vaginal wall. Any weakness in the supports lead to the prolapse of the uterus. So this is all about the uterus. It's a applied anatomy.